first time I haven't had to go to test committee for this test. So you guys are doing so good. I'm so proud of you this morning. So that also means we're 2/3 of the way done. So obviously one more block of peds to go. And I up front told you block 1 was going to be the easiest, most straightforward. Block 2 is going to be your bread and butter pediatrics, things that you guys are going to manage as PAs. Block 3 is in the middle of that. So most of block 3 is going to be things that I need you to recognize. I need you to be able to identify, do the initial workups, and then where do I get this kid? So that's going to be your biggest kind of reframing way to think about this. The other part of block 3 is that for a lot of these specialty subjects, you could go one of two ways. So I could either say, let's talk about all these esoteric things that you may or may not ever see in your career that may or may not be on your boards, but that exist out in the pediatric space. Or we could do some of the more higher yield topics in a pediatric light and get you more reps in for pants practice. And so I've gone a little bit more in that direction. So if you feel like, my hope is that you're annoyed by the end of this course of like, yeah, we already know this stuff. We've heard this. And it's familiar so that you're getting those reps in with it. So that's my thought. Would love feedback on some of that at the end of what you guys are thinking. If you want esoteric, really unique things like that, we can do that as well. So that's where we're going with that. So if you feel in this block, you're like, yeah, this is a little bit of neuro, like what's the specifics here? That is some of the reasoning behind why. So I would say if you're looking at gauging study-wise, block 1 is the easiest, block 2 is the hardest, block 3 is somewhere in the middle. So just so you have that awareness. Let's see, so your objectives again, I will go over those numbers as usual. So when we are talking about seizures, in general, the place to start for PEDS neuro, if you think about really what a seizure is, it's just uncontrolled electrical activity. So something has caused everything to go haywire of this. And it's actually one of those pretty common things that you see in a lot of kids. So people they're seizure phobic, they're very afraid of seizures, but pretty common. If you think 1 out of 10 kids is going to have some type of uncontrolled electrical activity in a lifetime. And that makes sense, right? You're taking this small little cockroach entity and growing them into a full-grown adult. There's going to be some of those weird electrical things that happen sometimes. What epilepsy is going to be in children then is when you see this continuously happen and unprovoked. Okay? So if I come and hit you in the head, or there's a car accident, a trauma, concussion, there's some sort of provoked event, that makes sense that you're going to have this uncoordinated electrical activity. If it's just unprovoked and out of nowhere, that's when you start seeing childhood epilepsy. So the ones that we're really going to talk about are, when is it focal, so just one part of the brain is going haywire? When is it generalized and it's diffuse across the brain? And then really we're not going to talk as much about the unknown or unclassified onset. That's really outside the scope of a family med PA. It's really outside my scope even too. So for PEDS neurology, they do pediatrics and then another 3 years in neurology. So that's outside of all of our scopes. So we'll just stick to those first 2. So when we're talking about generalized seizure activity, remember that is meaning that it is the full brain. So diffusely across both hemispheres, you see both those tonic-clonic movements. We're going to talk about the different types of that versus your focal seizures. So just one part of that brain is affected. The difference between your focal with your simple and complex is only your awareness state, your mental status, your consciousness level. So we'll go into those in detail. The super, super frustrating part of pediatric seizures is that 3/4 of them, we have no idea what happens. No idea. So that is one of the most frustrating things that you're going to start seeing in this. So the next thing is going to be a trauma. Kids love to find a way to hurt themselves. So they fall out of a tree. Is there a car accident? Is there a concussion in sports? Some sort of traumatic event. It's going to be your next most common thing. And then your electrolyte abnormalities. As this little human is growing up, what sort of electrolytes? These are going to be those same ones for adults, but children are really, really sensitive to these early. So when I think about my electrolytes, it's going to be those same 4 every single time. So those are the ones that you need to make sure I know. Is my sodium okay? Is my calcium okay? Is my magnesium okay? Is my glucose okay? So your 4 electrolytes to be able to think about all the time for seizure management. Certainly infectious, pulling those back from block 2. Some of your lesions with brain tumors, we'll talk about that in HEMOM. And then if you're thinking about really what the most common entity is going to be, is that fever. So a febrile seizure is what we see the most common in children. Your history is going to look like always your OPQRST or some sample history or some version of that that you're going to look at. And some of that is difficult. You ask a parent, how long were they seizing for? The most common answer I get, what do you think is?
Forever.
Forever, exactly. It felt like forever. And so I will literally start my watch and say, okay, tell me how long you think it was. And most of them get to about a minute, and a minute feels like forever to a parent. When you're thinking about what's progressing, remember we're talking about tonic, clonic. So you have the tonic movements where you have all the muscles that are contracting. So that's the tonic phase. So that can look very different for each child. Some of that means the muscles contract, some the eyes are moving, some have a specific stereotypic movement that they're going to do, and then they hold that contraction. And then the clonic part is the spastic and that rhythmic jerking motion. The 2 things that I want to point to at the bottom are things to think about in the setting of, is this a true seizure or not? So you will see and you will find that patients will think that you are an idiot and that you have had no training. And one of the things that they will try to do is they will try to fake seizures. And some of them have pretty darn good fake seizures. Like their acting is on point. Some of these 2 things are the things that will make you think this is more likely that it's a seizure. Most people don't have the level of committing to incontinence with their fake seizures. And then they forget that they're supposed to be post-ictal. So if you have a child or a teenager, is really where I've seen this happen, who has incontinence and who has that post-ictal period, more likely that's a true genuine seizure. That post-ictal phase also after the seizure is typically in correlation with how long their brain was seizing. So if you think about that, if you have some sort of gigantic electrical outage of the house or some building, and how long is it going to take to reboot that whole system is usually in correlation to how long the system was out or what sort of hit the system took. So your post-ictal phase, a little bit longer depending on the length and the longer the seizure. If you had to guess, it's typically I would say about 30 minutes is your post-ictal phase. Labs for kids is going to be indicated by your history. What I will say, the only real lab that I truly always get for a first-time seizure is a glucose, because that is the easiest one to miss. So I'm like, seizure, glucose, seizure, glucose, seizure, glucose. Those should just go together in your head. But there's really no standard lab evaluation that you are going to get. Everything is going to be dictated by what is the circumstance that is happening with that child. The question is then, what about in the adult world? Adults don't really have seizures all that much, so we're probably going to scan if they're doing something weird. You don't do that in kids. So if you are not concerned that it is focal, so focal is always going to be something that's telling you it's one part of that brain, or if you think there's some sort of mass effect, which would make it more likely focal, or a bleed from some sort of trauma, then there's really no standard imaging that's going to be done either. Your EEGs, these are not fast, not super helpful, and a lot of times they will even be normal when you're actively seizing. So this is not going to be something that you are going to standardly order, especially in an ER type setting. This would be something usually that the neurologist, the case neurologist is going to determine. Can be done sometimes, but if you really think about it, a lot of times people will think that an EEG is like an EKG or ECG for the brain. But you guys have an ECG class. Notice there's no EEG class. It's a fellowship on top of case neurology, where that. Again, way out of our scope. So you're really thinking, is that really what I need to order today in a clinical setting or even in an ER setting? Probably not. EEG is not going to be your go-to. The referral to neurology is going to, this is one where you actually, I'm going to send most of these kiddos, and we'll talk about the ones you don't send, to neurology. And the common things being common, most kids are going to be put on one of two meds, oxcarbazepine, or the one that I can't ever say, levetiracetam or whatever. I'm going to call it Keppra for the rest of this lecture. It's just Keppra, because I can't even say it. When we talk about that, because a lot of the kids, it's refer to neuro, they'll determine, and our same drugs of oxcarb or Keppra, the way to study this will be, okay, which kids is that not the case for? So that's going to be the common pattern that you're seeing. When we're looking then at focal seizures, so this was that subtype, we had generalized, and now we have focal. So the focal specific type has those two types, simple or complex, depending on your preserved consciousness or preserved awareness versus not. So anytime, again, that it is focal, you're going to know that this is just that one part of the brain, and while it may once it starts to trigger that uncontrolled electrical activity, it can spread. It's usually going to stay in that focal area, so something to be aware of. Your consciousness here is preserved, and some of the times this is those sensory auras that they can help tell you about that. So now remember what some of the common things that people will notice with these sensory auras, like smells. What are some of the common smells? Do you remember that from neuro? Burning, some sort of burning plastic, burning toast, burning rubber, something like that. It's like a burning smell, and so kids will say that too. That they'll sometimes smell something first. Sometimes you'll see it in a visual aura. The most common is going to be smell. And then they'll have some sort of motor association with this, but again, it will typically fall that one side in that one specific focal area. Can be minutes, can be hours. And the thing to know and to differentiate this on your pants or in real life or on anything is this involuntary control of the child? So a tick, even if it is difficult, can be suppressed. So if you do something with a child, you move their arm down, and they really want to do it, but they can suppress it, more like a tick, versus this is completely outside of any kind of voluntary control, more seizure pattern. This would be the time where I would consider a head CT because it is focal in nature, so you do want to know if something is going on. And when you do have that focal area, more likely that you're going to be able to catch something on EEG, so that can sometimes be a little bit helpful. And look, our treatment is the exact same thing. Neuro, same two meds. So pretty standard across the board for PED neurotherapy. When you have the impaired consciousness now, so focal seizures with your impaired consciousness, more likely if it's in a little bit of an older child, so by the numbers will say less likely if they're under the age of 7. What I wonder is if they even really remember this, so anyway, don't worry about that specific number. See this more in older kids. Similar symptoms now, but your conscious level is different. Same things, and again, they just will not recall this. Consider your head CT, consider your EEG. They go to neuro and they get the same two meds, right? So you're seeing this pattern over and over. So what I want you to take away is this new, have I checked my electrolytes? Do I need that head CT scan because it's something focal or a mass effect or there was trauma associated with it? Do I really need to get an EEG right now? Or am I going to let neuro and the same oxcarb and Keppra be the same go-tos? Start seeing those over and over. Oh, but wait, but now we have absence seizures. I have no idea why we have to say them as absence. Absence, but we do. So this one is the specific one. So if you're looking for something that would be easy for the pants to test, this is always one of those ones because the way that it can present and what it can mimic in kids, and because your treatment and your testing is very different. So just test-taking strategies there. This typically is going to start in that early school age child. And because they look like they're having these staring episodes, so they can be very, very brief. It can be like a second where they just kind of have a staring or a blinking, or this could be up to maybe 15 seconds around that time period. But think about it, you now have a child who starts school and who looks like they're zoning out, or they look like they're just blinking and nothing's happening, or they're not paying attention, or they're not catching on to concepts. Is that truly a learning disability? Is that ADHD? Or are they having hundreds and hundreds of seizures every day, and that is why they can't learn? So the presentation can be a little bit hard to differentiate there, and your differential can be quite long because it sometimes is not noticed that this is actually seizure activity. Obviously, it's going to look a little bit more like seizure activity if they have the eyelid flutter or upward rolling of the eyes every time this happens, but truly the kids that I've seen this with, you kind of get the big blink or the big stare, and that is really all. No postictal period, so that's a difference here. As soon as they kind of snap out of it, they're back with it. So it's an interruption from that 1 to 15 seconds, and then they're back to it. And then the two big things to notice then are your EEG pattern is super specific. The 3 Hz spike and wave pattern, I could not tell you if there was a gun to my head what that looks like on an EKG, but that is on every board exam. The 3 Hz spike and wave pattern. So that would be one. We always tell you don't word associate. I'll just tell you right now, that's one to word associate. 3 Hz spike and wave pattern, and then ethosuximide is your treatment. So that's why this is such a high yield testing thing, is because your treatment's different, your diagnostics are different, your presentation is specifically different for kids. So to be aware, and your differential is different, a little bit longer. But here's the meat and potatoes, this most common one. So we're really talking a bit about febrile seizures. This is going to be your most common thing that we see all the time. So typically those kids are going to be between 6 months and 5 years old. And almost, potentially up to half of them can have recurrent febrile seizures. Why are febrile seizures not considered epilepsy? Yeah, it's provoked. There's a source. There's a reason that this is happening. So if you think about this and really what's going on with children, are children's immune systems more or less robust than an adult? Immune systems? Are children's immune systems more or less robust than adults?
Reactive? More.
Yeah, they're more. If you think about it, every kid that every time they get sick, they have a rash. Every time they get sick, they're having a fever. Every time they get sick from every time they're around a bug. Think about daycare settings, right? So their immune systems respond to everything all the time. And they're very, very robust. So they haven't figured out kind of where that sweet spot is. Okay? So now you have a kid who comes into contact with something that's going to cause a fever. How fast have you guys been around children who are fine 1 minute and then all of a sudden their fever spikes? Like, where did that come from? I thought you were fine like an hour ago. You just took a nap and now you woke up and you're 104 degrees. Yes, so that's kind of the thought with febrile seizure, is the boiling frog theory, right? If you put a frog into cold water and you slowly turn up the temperature, the frog will just stay in the pot of water. No big deal. If you put a frog in a boiling pot of water, the frog is going to jump out. Okay? That's what's happening with the brain in febrile seizures. All of a sudden, the thermostat gets turned up, the brain seizes. Because it is like, wait a second, what's going on? And it's like the frog jumping out of the boiling pot. So that's what's going on with febrile seizures. Who's getting the most fevers, and who is the most sensitive to those particular changes? Well, 6 months to about 5 years old. I classically learned it 6 months to 6 years. It's kind of the age range that you're learning. Anytime they have that true fever, and it doesn't necessarily need to be a particular spike. So can you have a febrile seizure at 101? Sure. Yep, can you have a febrile seizure at 104? Yes. Can you not have a febrile seizure at 105? Yeah. Can you not have a febrile seizure at 100.5? Yes. So the specific temperature does not matter. So people will often ask, well, the temperature is 103.5 or 104 or 104.5. Do I need to go to the emergency room? I'm worried about a seizure. It has nothing to do with the overall number of fever. How fast did you get there? That's going to be one of the things. This also has to have no other things besides the fever as the reason that you think that the CNS was involved. So if you think, oh, well, I think they have meningitis as the cause of this fever, then you cannot say it is just truly a febrile seizure. If you think they have a hypoglycemic event and fever because they're dehydrated or they've been sick, then not truly just a febrile seizure. So it has to be in the absence of everything else going on. How do you classify then if it's a simple or a complex febrile seizure? I would just star this slide for the future. So simple means it's just that. The kid in an age range that we expect had a fever just like we expect. Their immune system was very robust and their brain just could not handle that. It was too much too fast, an electrical short circuit, and we reset. Right? So a febrile seizure. What does that typically look like? Well, it's going to be a generalized seizure because the whole body, the whole brain is febrile. It's not just like a little focal part that I have a fever over here and I don't over here. So it's going to be generalized. It's going to be pretty short. If you think about this, it's functionally the brain's response to the immune system that is being too robust. Right? So it's like, whoa, chill out a little bit, immune system. And it's kind of like a reset, short circuited out a little bit, just resetting. And it has to occur no more than one time in a 24-hour period. That is the limit. If those are the case, so if you have a 6-month to 6-year-old that is a generalized seizure, they have a true fever, it didn't happen more than once in a 24-hour period, and it was less than 15 minutes, that's a simple febrile seizure. That is such a good prognosis. They are not having any additional risk for epilepsy than you or I. No other increased risk at all. It's when you have anything that's not that you increase your risk. So if now you have a complex febrile seizure, something is going on. So it's either focal on exam, and you're like, wait, fever was generalized. Now something's focal, and there's a fever. Do I have an abscess? Do I have meningitis? Do I have encephalitis? What's going on? So you're outside of that realm. It's no longer just simple. It's more than 15 minutes. I expect their brain to not short circuit for more than 15 minutes, so that would be outside the norm. If it's happening more than once in that 24-hour period, or if they have something underlying. So this also assumes that your child is neurotypical, a healthy, quote-unquote, neurotypical child at baseline. So if they weren't that, that's going to be one of the things that already disqualifies it. They're more likely at that point to have, epidemiologically, to have epilepsy. To be able to know, if I give you a simple febrile seizure, what you do versus if it's a complex, who needs to see that, what's your workup look like? Are you worried or you're not worried? This slide has caused some heartburn over the year, since I've been here. So when I say that you need to rule out meningitis, encephalitis, and brain abscess, I'm not saying that you need to do a lumbar puncture. I'm saying that you need to use your provider brain to be able to say, do I need to do that workup? Or is this really not the clinical picture, not the risk factors, not the physical exam that would warrant that? Okay, so not every child that comes in with a febrile seizure needs to have a lumbar puncture. Most don't, unless they are one of those focal or they're a risk factor, right? So if I tell you on an exam, they have palpable purpura and they are unvaccinated, well, then yes, then they're probably going to need that, even if they had a seizure at the presentation. If I tell you this is a 4-year-old, everyone at daycare is sick, spiked a fever up to 103, now they've been fine, probably don't need a lumbar puncture. Again, if there's anything focal, this is probably been there 100 times in this lecture, anything focal is going to need that CT scan because I'm worried about some sort of mass effect. Certainly before you do any lumbar puncture. And again, why is that? Herniation. Yep, so I'm worried about herniation if I do a lumbar puncture in the setting of a mass effect. And CT, so this would be one time where you really would CT a child. So we haven't really talked about a lot of times where you're going to CT scan a kid. This would be another one of those times if you were really thinking what's going on. If you're in clinic and they tell you, oh, there was a seizure, there was something that happened, they didn't do any imaging, we were on family vacation, we were on something in a subclinical setting, meaning I'm out in an outpatient clinic, in that case, it would be very reasonable to get an MRI. And for children, why do you think that MRIs are better for children? And what can you see on the brain in an MRI that you have trouble seeing on a CT scan? Some, yeah. So the posterior fossa is really hard to see on a CT scan, and so MRI has a lot better view of your posterior fossa, and that's where a lot of tumors be found in kids. So when you have that clinical situation, that would be a time as an outpatient then to go ahead and get your MRI versus your acute setting, they've acutely presented and you're worried about something, that would be more the time to get a CT scan. Your EEG can be helpful, not as helpful, especially with febrile seizures, you're not going to see anything, they're all going to be negative. And genuinely, this is a simple febrile seizure, nothing to write home about. Neurology does not need to be consulted. You don't need that EEG, you don't need imaging. It's something very much handled at the primary care level. So usually brief, usually benign, great outcome. They don't require any kind of treatment. And when they say no treatment, that really doesn't, they don't need any seizure prophylaxis. They don't need any kind of management other than you would do for a regular fever control of any other child. They should be returning to their baseline, so a prolonged post-ictal state would also be something that would make you think that's not normal, that's not right. And if they're in that high-risk category, so a high-risk seizure would be something where your brain is seizing longer than 5 minutes. So what electrolyte gets used a lot when you're seizing? Glucose, yeah. So that's one thing to consider too, is that children are very sensitive to those glucose changes. And so for 5 minutes, after 5 minutes, we want that seizure to stop. We can't see the brain is not continuing to consume glucose. So rectal diazepam could be something to consider giving those families if they're having these prolonged seizures. And no seizure management. And one of the things that you will often see as incorrect management is that it is not recommended that children who have had or are prone to having febrile seizures should not be on round-the-clock antipyretics. It has not been shown in the literature that it helps prevent any kind of future febrile seizures, and it ends up with higher incidences of overdosing the child on Tylenol and Motrin, just even negative. So, not recommended to keep it around the clock for anything. You also don't know when they're going to get sick, and so that first fever could be just as likely to have a febrile seizure. So, not recommended there. When you're talking about what do you do for children, or if you are asked, there was one of the bases I got to, they said, hey, guess what, you're in charge of the CDC for all the children. And this next week the CDC was like, can you do seizure management? What? Okay. So things to talk about when you're talking about children. So first off, if you see a child that's wearing a tie, I don't know what school they're going to. Maybe some uniforms have that. But things to be aware of when you are doing this. You have parents that will want to basically hold the child down and keep them safe. No, you just want to make sure their head is cushioned. Anything tight is off of them. So sometimes for a baby that could be in a bib that's around them. It could be in something like that they have going on. Turning them on their side so that their airway is clear. Timing it. So a lot of times that gives parents something to do. I'm going to time this event so I know exactly how long this is. Don't put anything in their mouth to bite down on. Don't put your finger in the mouth. don't even know what they're doing. And then again, don't hold them down. One of the things we see is that there's oftentimes poor management of seizures in children, especially in the school setting. It goes one of two ways. They either try to hold them down and it's the Wild West, or they don't do anything and then they have rectal diazepam, and for numerous reasons nobody ever ends up getting it. So you see kind of both sides with children in the way that it's managed. So things to consider for these children and teenagers too. So can these teenagers drive? So it's going to be the same thing as the adults. So they shouldn't drive within six months of the seizure, which, by the way, is kind of interesting because that's self-reported. So if you really think about that, that is 6 months of a patient self-reporting when they last had a seizure. So think about that when you're on the road. It's a patient report. Swimming should be one. While you should never have a child unsupervised in a swimming or pool situation, this would be a child to make sure that you truly have eyes on to make sure they're not seizing in the pool. And then for your sports physicals, way back to block 1, it's going to be a difference in what this child can do. Know your risk stratifications. Are they in group 1, 2, or 3? So group 1 is going to be basically if they started seizing in the middle of the activity, there would be no harm to them or anyone else. So thinking about golf as your perfect thing. If somebody started seizing during a round of golf, they're probably not going to hurt themselves, they're probably not going to hurt anybody else. Group 2, they might hurt themselves, but they're unlikely to hurt anyone else, which is why I have a really big problem with archery being in group 2. There's just, I don't know. I think archery should be group 3, but they didn't ask me. And then group 3 would be, they would be likely, if they started seizing in the middle of this event, to hurt themselves and to hurt somebody else. That is those classifications. And you know what? Kind of biathlon too. You know, like now that I think about that, I don't love the group 2, but so anyway, biathlon and archery, I guess I have problems with both of those spots. There we go. Now, if your brain continues to seize, you are using up all of this glucose. You are short-circuiting for a long time. You are a child with a developing brain. That's super concerning for status epilepticus, and we are concerned about that. So this is in children when this is going over 30 minutes. So I know that's a little bit different than the adult world because you are different. So from the child, right? So this is a different time amount than your adults, a little bit longer, because the child can hang for a little bit, and then at some point we're like, we're not good anymore. I think over the course, while we are all providers together, it's going to be somewhere in the middle. We'll probably end up at 15 minutes, but it's either here or there. Right now, I need you guys to know that it's 30 minutes for children to be status epilepticus. This can be a source of mortality. So if you cannot get these under control, we haven't talked a lot about what is going to kill this child. We see this here. So what are the causes of status? Well, this could be the first time that they've ever had a seizure. This could be their first presentation and nobody knew what to do, or it took a long time to get somewhere. So new onset seizure could be one of your causes. One of the most common causes, and this is wild to me, but it happens, is medication withdrawal. So they're just seizing, nobody knows what's going on, and then you go take a history from the parents and like, oh yeah, they have seizures, they have epilepsy. We ran out of medicine a month ago. Okay, that's probably why they're seizing today. Another thing that happens with kids, what are kids doing all the time? They're growing. So how are doses done in kids? By weight, right? So a lot of times they will just outgrow their effective dose of medication and they need it recalculated based on their new and updated weight. That's one of the things that we see. Your same electrolyte imbalances, what are your 4 electrolytes? Sodium, potassium, calcium, magnesium, and glucose. Good. Always hypoxia. We had a very sad case. We had a kiddo that had drop seizure, and he ended up kinking his airway, and he was found then unresponsive after that, and in a vegetative state post that. So hypoxia can lead to a status that can lead to a really, really bad outcome. So something to think about there. Certainly trauma. You do have infantile strokes or neonatal strokes or strokes in children. It's rare, but you do see that sometimes. And then infection is always on that differential there. Your treatments in general, what I need you guys to focus on mostly is that it's supportive care in an ICU setting. So status is going to be into the PICU. Your ABCs are always going to come first, making sure their airway is under control. While yes, oxygen, yes, IV status or IV access is going to be super important. Again, thinking this is mostly supportive care. Your electrolytes are what I would check first. There's just part of the slide. Your same ones that I always talked about. And this is nice because you can get the anticonvulsive dose. So I could order a Keppra level. I can order an oxcarb level to see is it in a therapeutic range. So that is one nice thing that you can get in neurology is those drug levels. Certainly any toxicology studies that are available. Kids love to eat all kinds of things. So if they are eating something, this would be a tox thing that I would check as well. And then pick a PAM, any PAM, give your PAM. Diazepam, Dazolam, Lorazepam, pick a PAM. Most of the time, you will end up doing either of them. And then a PAM, and then there's a loading dose, and then you will give Lorazepam as needed. Headache, treatment. Okay, so any questions on seizures? It's a little different than adult, mostly the same thing. So really focus in on your febrile seizures as kind of the biggest area. Some of those red flags, when do you image, when do you not? Common things being common. Headaches are common. You are going to see this probably every day in your practice in some form or fashion. So this would be one of those times where you see where they are little humans. So they have primary and secondary headaches, just like the adults. One of the, which primary headache is not up here? Cluster headaches. Guess how many times I've seen cluster headaches in a child? Never. So that is one of the reasons that we don't talk about it, just so rare. That would be an indication if you really think that a child is having cluster type headaches to get them over to neurology right away, because that's not typical. Okay? So we're not even going to talk about that. So migraines, tension type headaches, secondary headaches, you guys have been doing that all of block 2, right? It's part of that URI, be part of sinusitis. The biggest thing with secondary headaches is that they fall into 2 categories. Secondary headaches either are super serious and life-threatening or not serious and they're going to be just fine, right? Is this a brain tumor in this child or do they have a cold? You have 2 camps. Serious, not serious, and then are they toxic, non-toxic? So something to be aware of for secondary headaches. This is why all things neuro gets very heightened awareness sometimes to it because it really splits into it's totally fine or you're going to die from it. So that's one of those splitting points. And then your migraines and your tension headaches are what we're going to focus on. So red flags, this is what I need you guys to know too. Red flags, these are the things that you will see. And the ones that, yes, you guys have had buzzwords for worst headache of my life. Be careful if you hear that in a teenager, right? In a teenager, everything's the worst of their entire life, right? It's the worst breakup of their life. It's the worst day of their life. It was the worst moment of their life. So be careful with that. Usually, I will say the PANCE doesn't give you that. Board exams won't give you that in a teenager. So if the teenager is saying that, look for other things in that question stem. One's particularly for the child. So a pain that awakes the child. So if the pain is what's waking the child up, that's a really big red flag. It's a little bit different than I woke up and I have a headache. If it's waking the kiddo up, that is something that is an absolute red flag. Morning and recurrent vomiting is probably one of the most common things you'll see. Certainly focal, changes in position. So if it's better laying down, you're like, that's weird. Or worse laying down, sorry, that's weird. And then if there's no family history, so Kids with primary headaches will typically have a family history. Right? I have migraines, my mom has migraines, my grandma has migraines, some sort of history that's consistent with that. If a child is giving you new onset headaches without a family history, that would be something to at least investigate a little further. Retention type, thing that I want you guys to take away that's a little different with kids is that, and think about it with adults, tension type headaches typically do not interrupt your life. It's annoying, it hurts, it's real, but you're typically, people with tension headaches aren't missing work, missing school, unable to go play soccer games. It's there, it's kind of in the background, but it's really not disrupting their life. So if they're coming to you with a history of this as a child, it's typically either been going on for a long time or it's getting worse. Typically that's just not the presentation of this. A lot of times kids will have a hard time explaining what this feels like to them. And so when I say if it's painful or squeezing or their whole head, I will literally take their hand and I will say, does it feel like this? And I'll squeeze their little hand. And it's like, is that what it feels like on your head? Don't squeeze their head, right? Just squeeze their little hand. And sometimes that can help them as far as how to describe that to you. It's typically not going to have nausea, photophobia, phonophobia, really not consistent with that. And look for something else in a question or in real life. If you have a kid that's having these tension type headaches, is there a divorce? Are they being bullied? Is like something else is going on? Typically is what you're looking for. Contrast this to a migraine in a kid. They typically are going to have a family history of this. So I think the number, 90%. So if a kid has something that sounds like a migraine to you and there is zero family history, that should be something to at least think twice about. It's probably still a migraine, but you should have that secondary thought of, is this just a migraine? Because it typically will have a family history of this. It's the same presentation then as adults. You're looking at that. You can be bilateral, but usually unilateral, severe pain, pounding, throbbing, light sensitive, noise sensitive, sometimes has an aura, all of those things. Very, very similar that you see with this. And this one typically will impact their lives. If you think about that, people that you know with migraines, maybe yourself, God forbid, that is going to be a little bit different than those tension headaches. Migraines are the ones that I've missed a day of work, I have to miss school, I can't go to my gymnastics meet, I can't do piano lessons today, whatever it is, because this is truly disruptive to their life. So they will typically, especially as children, present a little bit earlier where you're seeing this pattern unfold. Your first line medication for, or management for migraine treatments, first line is either going to be acetaminophen or any of your NSAIDs. Some people will argue for acetaminophen, some people will argue for your NSAIDs. Bottom line, that is your first line conservative management, one of the two of those. What would happen with NSAIDs particularly though, is if they're using it every day, you end up with a rebound headache from the recurrent use of NSAIDs. So sometimes you don't even realize that they're making the problem worse by taking it every single day. So if you really think this child needs something every single day, let's use something else. We'll talk about that in a little bit. Can always use hydration and Zofran if you need to. So Zofran or ondansetron or promethazine. What's promethazine going to do to them? It's going to knock them out. Yep. So that's going to just zonk them. So really not one that you use a whole lot. Use ondansetron a lot more. And then your second line. So that's going to be if you're going to do that in clinic or in an ED setting. Second line is going to be your triptans. Remember how you give your triptans? You can give them all kinds of different ways, but do you give it like prophylactically or give it at the beginning of a headache? Do you do, yeah, it's an abortive medication, right? So you're giving it as soon as you can, as soon as you have an aura, as soon as the headache is starting to try to abort that headache. Not, again, as a reminder from neuro, not going to be for those basilar migraines, increases your stroke risk. And then also, secondary reminder, have that migraine with aura, that would be a kiddo that you're not going to give OCPs to. Right? So that would be a really hard question. It would be a tricky question. Acne medication, you're thinking, oh, I'm going to give you an OCP as well to help with your acne. Oh, but you have migraine with aura. Oh, no, I can't get that combined OCP. Something to think about. Yes?
Does that mean we discontinue that? If you have someone that has migraines, you have them on whatever, and then they're already on OCPs and they start getting migraines, you discontinue the OCPs.
That's a tricky question if you should discontinue or not. I even phone friends with OB-GYNs, but what is the risk? And looking those up because it's going to be patient dependent at that point. Because they've already shown you that they do well on those, right? So it's going to make it worse, better. What I think these guidelines will, I think again in the course of while we are all practicing, that migraine with aura will no longer be a contraindication. So I tend to, if they're already on it, keep things the same, but something. So prophylaxis. So now you're like, oh, I don't want to give you ibuprofen or Tylenol every day. You're going to get these rebound headaches. And I don't want to give you triptans all the time. The promethazine is going to knock you out. So let's see. Well, we got some beta blockers. We got some TCAs, anticonvulsive, calcium channel blockers, antihistamines. Huh. Well, which one's the best to use there? Trick question. None of them work awesome. Doing kids, any of these work between 40 and 50% of the time. So pick one, any one, right? One of the bases I was at, the wait time for neurology was about 9 months for PED neurology, right? So you are then the PCM that has this kid, you're like, well, okay, knowing that by the data, it all kind of works like a coin flip. I got to be really good. I picked topiramate and cyproheptadine. There were, oh, it says right there, antihistamine. Cyproheptadine, it's kind of interesting. It's terrible antihistamine. Literally terrible drug, terrible antihistamine. But it helped with appetite stimulation and it helped for migraine prophylaxis. So don't use it as an antihistamine. But if you need a kid to eat migraines, it's a pretty safe one to use, right? So I use cyproheptadine. And then, oh, we still got 6 months till the neurologist can see you. Let's try one other one. So I got used to topiramate. So the bottom line is, for any of these prophylactic daily medications, ultimately it doesn't matter what you use. Pick one or two, get comfortable and good at that as a PCM, and then we'll let it fly after that. Because you're going to have these increased wait times. There's a lot more of us than there are pediatric neurologists. I will tell you, I'm not going to ask you specific types of secondary migraine prophylaxis. Be aware of the classes that you could use, but I'm not going to get into dosing or anything like specific. Oh, it's a good time to take a break. So, top of the hour. Okay, secondary headaches. Exactly what I said before. It's either big, bad, scary, or we're totally fine and this is a symptom or side effect of everything else. So, a couple of things to think about with medication overuse, particularly in teenagers. Remember we talked about one from last block, they love to use Afrin. So if they're trying to come off of Afrin, that could be one of the reasons for that. The other one that you see in teenagers is caffeine withdrawal. You often won't think about caffeine as a drug, but that's something to consider, especially because they're like, well, I drank 3 Monsters, I drank a Red Bull, the Trinity thing at Starbucks. They don't realize how much caffeine they're intaking until they're somewhere where they can't have that much. And then the big bad other stuff, we'll talk about a couple of those entities. The red flags then for your secondary headaches are very similar to the other ones, but something that I just always think about. So this is not those primary headaches, so it's very similar to those red flags, but if it is very first thing in the morning, you should feel the very best. If you're a child, not an adult, adults who wake up and you're like, am I sick, am I dead, like every morning. A child wakes up and they're just like ready to go live life, right? So if they wake up and they're like, they feel terrible, or if laying down is worse, it's something to think about. That's not normal childhood behavior. Okay? It awakes them from sleep, so not that they wake up with it, it wakes them up. And then the other ones are the things that you're used to. The ICP, the papilledema, and worsening from some sort of intra-abdominal pressure or valsalva. Okay, so when you're then doing this evaluation, so I'm doing my physical and history, history and physical, my goodness, I'm starting to have a stroke, here we go. Looking for those red flag symptoms as always, so this would be the time where you're really doing a full neuro exam, even for a child. Who am I going to image? So these would be the things to know. So I have an abnormal neuro exam. So kids should not have abnormal neuro exams, right? Adults will be like, I have this frozen shoulder, or like, I had this nerve I can't feel, like from the army from 27 years or whatever happens. That's not normal for kids. So any kind of abnormal neuro exam in a child should prompt you to get imaging. Something that's not normal during a headache. So if they tell you something that's off the wall, like I can't feel my face in the middle of a headache. Something where you're like, I haven't heard that one. So if you start thinking that and they tell you some symptom that you're not used to hearing all the time, that should be like, well, that's not normal. I should think about imaging that. Certainly any kind of altered consciousness level, and then if it's chronically progressing, most headaches stay very similar. Your migraine is your typical migraine. It might have a little bit of a worse migraine, but it's not continuing to progress and get worse. Headaches are typically what they are, so a chronic and progressive, where it's continually getting worse, that should prompt you, I need to check what's going on in that brain. Again, things to think about. Your ED settings are going to be your head CT scans, your subclinical, your outpatient clinic. I have time, but something isn't sitting right. That MRI, where you can get that better look at that posterior fossa. Your treatment for any type of headache, besides those, especially for those migraine ones that we talked about, any type of headache, lifestyle modifications is going to be your first line treatment. So if you have that on any exam, lifestyle modifications is literally never not your first answer. Things to think about, particularly for kids. A lot of kids are breakfast skippers. A lot of adults are breakfast skippers, right? Are they like, I get a headache every day around 11. And they're like, do you eat breakfast? And they're like, no. And she's like, when's the last time you ate? And they're like, at dinner. They're like, so you didn't eat for 17 hours and you have a headache? Right? So, is there something with a lifestyle modification that you could help with, right? I only sleep 4 hours because I'm an iPad student. Your head probably hurts, right? That's probably home. I'm not calling all y'all out. I was here too. I was nervous in this. Known triggers, obviously we talked about some of those. And then again, are they using these medications too often and they're getting those rebound headaches? So a lot of education involved with how to do this, what to do. I usually give them, much like an asthma action plan, I give them their headache action plans. Here's your thing that you're going to do every day. You're going to wake up and you're going to drink 8 ounces of water. I'm just making things up off the top of my head right now. And you're going to take your ciprofloxacin for your migraines. Then if it's really bad, your first line medication is going to be Tylenol. Your second line is going to be ibuprofen, and if it's an abortive medication, you're going to use sumatriptan. So they have their headache action plans. One of the entities to consider in your differential then is going to be called idiopathic intracranial hypertension. So we used to call this pseudotumor cerebri. So if you've been in medicine a while, you've probably heard of a pseudotumor. If I tell a parent, your child has pseudotumor cerebri, what word do they hear? Tumor, right? How comfortable and calm are they after they hear that word? 0, right? So when I try to tell them, well, it's not really a tumor, the word tumor is just in it. It's like a pseudonym, but for a tumor, right? They're like, they're not having it, right? So we changed the name. Idiopathic intracranial hypertension, right? So it's in the name. We have no idea necessarily why this happens. It's increased pressure around the brain, increased fluid. This one becomes pretty debilitating. So this would be one of those examples where it starts out one way and it's chronic and it worsens as there's more pressure that's building up. One of the distinguishing factors of this is you'll start to see that it has vision changes. And so if you have headache plus vision changes in a kid where it's continuing to get worse, this should be one of those differentials. The way I've always seen it asked is it is in a female who has recently started contraceptives or a female who has recently started Accutane. It's going to be the most common way that you see this. And why Accutane? So yes, you have to be on birth control with Accutane, but what ultimately is vitamin A, as I said, yeah. Accutane is a vitamin A derivative, and high dose vitamin A is one of the causes of this. So Accutane can be one of the underlying causes you see as a reason for this. You can also see this in kids who rapidly put on weight. So you have a child who's very quickly gained weight. You can also see that increased pressure in the brain. Interesting to me, so yes, the treatment is referring to neurology and they will deal with some of that. So certainly if it's a triggering medication, you could stop the Accutane that day. So that would be something that you could absolutely do. Some diuretics are used, but it's also a super interesting thing to watch neurology do because they will do therapeutic lumbar punctures. So they will do an opening pressure when they put the needle in. They will see what that pressure is. So you can see how much hypertension is in the spinal column. And then they will take off an amount of fluid to allow the brain to kind of decompress. And then the kid immediately feels better. So it's one of those, like, a lot of times neurology, it's a sad specialty. They're like, you've had a stroke. And they just kind of stare at you. This is one where, like, they really help the child feel a whole lot better. Great. Okay, little check. This is question 51 of the test today. Which of the following is your initial treatment step in an adolescent who presents to the ED in status epilepticus? Do you want to give them IV glucose, stabilize their airway, AEG, diazepam, or stat EEG? Airway, yes. Same thing. Lifestyle modifications. Next, if you have airway as a pick airway every single time. Oh, so sad. Okay, so that transitions us out of that kind of stuff. Now we are talking about TBIs. So you can pick any kind of traumatic brain injury. So yes, we typically will think of it in some sort of sports or motorcycle crash or all kinds of those things. But what I really want to start impressing upon you is that TBI is that umbrella term. And so anything that is going to be traumatic to a child's developing brain is a TBI. So your concussion is a TBI. Your contusions, your small linear skull fractures in a baby, even though it's not child abuse necessarily, can still be considered a TBI, leading to that developing brain. Remember your intracranial hemorrhages, your 3 types, those are still the same types that you see in kids as you do with adults. We're going to kind of camp out here on concussion a little bit. So yes, the brain in this instance, it's not short-circuiting with the electric, it's short-circuiting because it has gotten jolted from that whatever kind of trauma that has happened. So your symptoms in these kids, yes, they're going to often present with headache, but really what you see in most children, the majority of them, you're going to see in cognitive and in emotional areas. So you have the child who's pretty happy-go-lucky that all of a sudden is completely emotional, will be labile, crying, tearful, like that's not normal. It's one of the things that you see with concussions. Other thing you see is the kiddo that suddenly cannot do school. So their attention span, headaches start during class, delay in their response times, you see all kinds of school issues. So emotions in school, in addition to these headaches, is a lot of what you see with that. Yes, sleep can be affected. Sometimes they want to sleep more, sometimes they have trouble with sleep. So you see both of those things. So those are the common symptoms. Certainly a concussion can have consciousness loss as well. Remember that you can have either retrograde or anterograde amnesia with either type, or with either of those types with a concussion. So just as a reminder, you get hit, you have that concussion, and you don't remember what happened before the event. That is retrograde. If you get hit, and now you remember what happened, but you can't recall new stuff, it's anterograde. However long that amnesia is typically correlative to how bad that trauma was. So if they remember everything, they remember that last play of the football, they just don't remember the guy hitting them, everything else is there and they're not having any interrograde amnesia, probably a lot better than I didn't even realize I was playing in that game that night. So that's kind of the way we see it. Oh, they still work. Yay. But I got fancy there for a minute. Things to think about. Artificial turf. It's going to be a little bit harder. Football or rugby. I would also say that female rugby should be on there as well. But female soccer. Athletes with a BMI of over 27. So you're like thinking, what is that? A lot of times with children, you think about body awareness. So if there is more body to be aware of, it is sometimes a little bit harder to control that and more likely to be at risk. And then if you train less than 3 hours, the other thought is that you don't have the body mechanics to be able to take potentially some of those hits well. So less training time, a bigger body, and then sports where you know you're going to have impact. Makes sense. Your recurrent concussions, we get worried that the brain is already inflamed, it is already pissed off, so you don't want to have a repeat concussion, especially in those first few days, those first 10 days. Certainly the longer you do sports where you're more likely to get hit like that, the more likely you are to have a concussion. And then just being a quarterback, you know you're going to take those sacks. So kids that are playing that early on, it's just something to talk about to those families about their risk level that they are assuming. So things with seizures, let's pull the beginning into now. So can you see seizures with concussions? Absolutely. Your brain's getting rocked. Is that always necessarily a bad thing? Well, not necessarily. So if that seizure happens at the time of injury or impact, you start thinking, that's a great prognosis. The brain got rocked. The brain was like, whoa, short circuits out, resets, excellent prognosis. That makes sense. If it's within that first week, it's still a pretty good prognosis because you think the brain got rocked, it concussed, now it's inflamed, it has localized edema, so it can short circuit from some of that. Do I expect that to go away? I do. So I expect that's going to be a pretty good prognosis. A little more unlikely, but it's still a really good prognosis. If the seizures come after you expect that localized edema to go away, it's a terrible prognosis because at that point it tells you that there's more scarring in the brain from the inflammatory process, and that scarring is causing the short circuiting because there's those pathways when they aren't there anymore. So the glial scarring from seizures that are way after that acute period of time, after a week, much, much worse prognosis. Typically your symptoms are going to be short and remitting. Kids' brains, even when they take those hits, they bounce back pretty well, so a couple of days. You can see it in prolonged, where they have had prior concussions, so the brain has already taken those hits. I'm not one to do CT scans unless I think that there is something focal. So times that I would get a CT scan. So these would be the ones that I would think about. Significant loss of consciousness. What do I mean, significant loss of consciousness? My cutoff as a provider is usually, were you out for more than a minute? Right? That's not a specific guideline, but really, if you were out, your brain took a hit, and you're back with it, your brain just reset. If you were out and didn't come right back, it's been a minute, let's check and make sure there's no bleed going on. You have that significant and worsening amnesia. That would be something, you don't remember what happened right before, right after, it's continued, that's a little bit higher risk. You're still altered, you still have something focal going on, you have evidence like the skull is beat in from a car accident, a motocross accident, something like that, I'm going to scan that. And if you're getting worse. So I expect after concussion, if I'm not rocking your brain anymore, that you're getting better, I don't expect you to continue to get worse. So those are the times where I would scan this kid, otherwise I'm not going to scan. I'm going to watch him, but I'm not going to scan. Certainly if your brain has edema around it, and that localized inflammatory response, you are at the significant and high risk of having a more permanent brain injury if you have that second impact syndrome. So this is one that within reason, this is why we exist as providers. We are trying to prevent the second impact syndrome and those 3 deaths, right? I might not be able to do anything about that car accident that that kid was in, but I can keep them out of football for a couple weeks to let their brain heal, right? I can't do anything about the first hit, but we can try to prevent the second hit, and that's the idea of limiting them from sports or other dangerous activities as you can. Or soldiers or airmen, whoever you're seeing. So yes, there's return to play guidelines for these kids. There's also return to learn guidelines, because you have to think of the 2 settings, so it's not just sports. School will be impacted as well, so I didn't put them specifically in here, but there's return to play and return to learn. So these ones, super tiny, right? That the biggest takeaway from your return to sports is that you can only do 1 step every 24 hours. That's it. So if you want Lindsay's personal opinion, how many steps are there? 6. How many days are there between NFL game and NFL game? 6 to 7. So it's kind of how these guidelines were probably done. Does the kid's brain probably get a little longer than 7 days? Yeah. I'll leave it at that. But, so everything, it's 1 day. You cannot complete more than 1 step in a day, but you could get back to a game in a week. So day 1, when I say no activity, I always say this is brain rest. Brain rest to a kid means you take away what? Their phones and their video games. Anything where they're going to have brain and significant eye engagement with whatever they're doing. So at least give them those 24 hours of complete physical and brain rest. Day 2, light stuff, you can start introducing it. Maybe that means a walk. Maybe that means you are just kind of up and around, check your phone for a little bit. Day 3, add a little bit of sports-specific stuff back in. No contact yet, but a little bit of some of that running, for instance, if they're doing soccer. Progressing on day 4, day 5 would be full contact, and then day 6 you're ready to go again. So the shortest you could do is about a week. Obviously, because the day of impact is day 0, not day 1. So you cannot complete day 1 on day 0. Yes?
It seemed that in like high school sports, some kid would get rocked, can't fall asleep. Where was that coming from?
Where is that coming from? So the idea of you can't fall asleep is do you have some sort of bleed that's going on that you're gonna miss? If you're outside of that 4 to 6 hour window, let the kids sleep. My gosh, give them brain rest.
That doesn't seem
Yeah, let them sleep. So the idea is if you're watching them clinically, they don't deteriorate, you don't think it's focal, you've given them that kind of 4 hours post-play, let them sleep. Yeah. So, but they were looking for these like epidural bleeds that they were fine and now they're not. Yeah. Crazy, right? Yes, ma'am. Oh, great question. So what do you do if they don't pass a step? You repeat that step until you pass it. So if day 1 you brain rest and then day 2 you start doing things and your symptoms come back, you repeat day 2 until day 2 is fine. And then you progress to day 3 and you do that and you're like, oh, we're good to go. We did sport specific stuff. Now we go to day 4, we're not fine, we stay at day 4 till we're fine. 3 questions. I expect this to be better in 2 weeks though, right? So 6 days, in my humble opinion, is a little short. It works, kids do okay. But I do expect them to be better at about that 2-week mark. So things that make it worse, the younger brain you are. The younger you are, the more development you have left, it's gonna be a risk factor. What was your level of play, right? Did you fall down on the grass yourself? Or did you get rocked by a 15-year-old that you were playing flag football with, something like that? Is it ongoing? Has it caused some personality changes at all? That's going to be something to think about. So the big severe ones, that if this is lasting, are the big severe ones, right? If you have a child who doesn't hallucinate normally, who starts hallucinating, we should call someone together, right? That's not normal. That's big and severe. Certainly sleep, thinking, headaches, those would be the normal things. So At this point, I think as clinicians, you are all starting to learn what is normal and is not normal. Can last days or weeks, and at that point, if you are really outside that norm, where you expect them to get better, you've done all of the processes, and it's been a couple of weeks at least, and really no change, that's when I start thinking, do we need to get neurology on board? Okay, big transition to sleep. So now you've told your children, hey, we don't want to keep you awake, as the football players in the room were kept awake. So now we want to sleep, so let's just talk a little bit when we go back to sleep. I don't know how much, did Major Rogers talk a lot about sleep in neuro at all? Not a whole lot? Okay. We're going to talk a little bit, because this is going to be one of the most common complaints. So just a reminder, yes, we have REM, non-REM. But when people are like, what is normal? We're talking about these newborn infants. They sleep like 18 hours a day. So it doesn't mean that they all do, but that's the average. So are you going to have some that sleep like 23 hours a day? Yeah. Are you going to have some that only sleep like 12? Yeah. We're in that range. So normal is about 16 to 18. It's going to get progressively less, obviously, as you get to an adult. And you're going to go from 6 naps to 5 to 4 to 3 to 2 to 1. And eventually, about school age, you're really not taking naps anymore. But really what I want your takeaway to be from here, rather than a specific number, is that all of these numbers are more than 8. So a child who is developing always needs more than 8 hours of sleep. So even your teenagers, 12 and older, are still recommended, and from a development standpoint, that they need 9 to 10 hours of sleep a day. Think back to your high school years. Did you get 9 to 10 hours of sleep a night? No. So if your medical opinion is asked someday, what time should we start high school? You think to yourself, well, I started 0 hour at 6:30. They should too. You're like, it doesn't really make sense physiologically. Okay, so you could get asked some of these questions someday. I know you love charts so much. Charts make you want to vomit, but we're going to do this together. Okay? And really, before we start going through all of those, we're talking about what a sleep history is. You're getting this from a family. One of the things that you will ask is, how do you sleep? Right? What's the kid going to say? How do you sleep at night? Fine. Okay, what does fine mean to you? I don't know. Right? So when I start asking sleep, I say, how many hours of sleep do you get? And then they'll tell me. I get 12. Okay, 12 hours of sleep. And you really start digging into that. What time do you go to bed? I go to bed at 8. Okay, what time do you fall asleep? Well, I don't fall asleep till 10. Okay, what time do you wake up? And what time do you get out of bed? How many times do you wake up in the night? That actually gives you a better history than how's your sleep? Because they might be in bed for 14 hours, but they're only asleep for 7. So it gives you an actual sleep history. When you're talking though about these little guys, so way back to newborns, so we're pulling in block 1 stuff. Your newborns are going to need to wake every couple of hours to keep their blood glucose up. So they should be waking to feed, and your bottle-fed babies who have those predictable amount of calories are going to sleep a little bit longer often than your breastfed babies. So, but it could be separated. They should in that 2 to 4 hour range somewhere in there. We always advocate against sharing a bed, but we will always say safe sleep could be sharing a room. In that first year of life, back to sleep, so all of that's a review. And then your developmentally normal behaviors, so you would see kiddos with those kind of myoclonic jerks, and the startle reflex, you see all that is normal stuff. So basically this slide is just a review from block 1 of what is normal baby sleep. Your little bit older infants is going to have all kinds of variability. So this is that, could be you are the parent that has a child that sleeps 20 hours, and you could be the parent that has a child that sleeps 12. Variability is wide here. This is when they start to learn self-soothing. If you recall back from block 1, we talked about the 4th trimester, where that colic happened, and where all their liver and everything was turning on. So those first 12 weeks are a little bit womb-like. So once they hit about 4 months old, they're able to self-soothe. So when parents will say, when can we start the cry it out method? What's the cry it out method mean? You leave them alone when you're sleep training them. Yep, and just let them cry and learn to self-soothe. They say, can I start that when they're 6 weeks old? Well, no, they don't have those self-soothing mechanisms neurologically yet. So about 4 months is when you would really say that would be a safe time to do that because neurologically they're able to do that. The other thing that you will start seeing is this is when they will, some of their self-soothing mechanisms really freak us out as adults. So we're like, really? The child is banging their head against the crib is self-soothing? Yeah. One of those self-soothing mechanisms or the rocking motions. You get a little bit older, now you're toddler age, you're starting to decrease and consolidate your sleep and your number of naps. Usually, that's a hard transition if any of you are parents in this room. The 2 naps to 1 nap a day is a hard one. You'll see parents that try to keep the 2 naps going for a long time. That's okay. The nighttime fears will start in those toddler years, and this is when establishing a routine is really important. So you think, really with the baby, with that 1 to 2 year old? Yes, we'll talk about why the next one. When you're looking at the preschool years, that is the large variability in naps as well. Everyone hopes that their child is in the 15% of 5-year-olds who will still nap, and that would be wonderful if they are. A lot of times they're not school ready at that point. When you don't have a good bedtime routine when they're 1 to 2, this is when you start seeing problems in the 3 to 5-year-old range. So if you are a co-sleeper when they are 1 to 2, you're going to have a very difficult time getting your 3, 4, 5-year-old out of your bed. So from parents' guidance, it might be easier right then, but you're going to have sleep problems later on because they are used to that co-sleeping. This is a lot of times in the 3 to 5-year-old range when your sleep problems become chronic issues. So better to intervene and get those sleep routines and the child self-soothing between 1 and 2 years old. Your middle school and your school-age children, this is when you start seeing it become a problem. This is when they are neurocognitively old enough to be able to start thinking through things at night. You start seeing that their media or electronics or things that happen during the day are starting to keep them awake. That's one of the things you see. Again, all of this is more than 8 hours, so even though it's consolidating here. And then your adolescents. So the best description I ever heard about this was really that their circadian rhythm is shifted from like a 24-hour clock to like a 25-hour clock. So as they're developing, they're truly not tired at night, and they want to sleep into the morning. That is when their body gets the best sleep. So if you think about all those people, these lazy teenagers, their bodies truly are not tired at that time, and they are getting their best sleep in those morning times. Ideally, you're keeping their sleep wake between 2 hours. So if you normally during the school day get up at 6:30, what time should you ideally recommend that they not get up past on a weekend? 8:30. What teenager do you know who's up at 8:30 on a weekend? Some, maybe. And then yeah, competing priorities. You know, a lot going on. Maybe they have a job. Maybe they are in the army. Who knows? A couple of different things. Then see, those charts weren't so bad. You can do most of those things. Not so bad. Focus on some of the things we talked about in large principles rather than memorizing everything on those terms. Your behavioral insomnias. So these are a couple of different things. So sleep onset. We'll talk about that with kids. Think about it from the adult standpoint. Have you ever fallen asleep on the couch? Ever? Wouldn't it be weird if you fell asleep on the couch and you woke up on your front yard? Right? Would you be startled if that happened? Maybe not at the end of iPad, you're like, I don't know, sure, maybe, it doesn't matter. Right? But that would be a very startling thing to be like, I fell asleep on my couch and now I'm in my front yard. That's a very startling event. That's very similar to when a child falls asleep on or in like somebody's arms or on them, and they wake up in their crib by themselves. That's a very similar thought pattern. So the recommendation is to put a child down to sleep, tired or drowsy but awake, so that they're falling asleep in the same environment that they're going to wake up in. Right? Is that always possible? Absolutely not. But it's one of those ways in that 1 to 2 year old period to encourage best sleep practices. The other type is limit setting subtype. So this is basically those bedtime routines, right? Where your child at night becomes like a philosopher. You're like, what is the meaning of life? I'm like, I need a tissue. There's a monster. I'm hungry. I'm thirsty. I have to, like, your covers are twisted. You're like, what is happening? Or they know the right words, right? So then they're like, I love you. We talk about life, love, God. What is happening? Right? So that is your limit setting subtype. So having a routine that you stick to every single night is helpful for those types. So this is when nighttime fears will also start too. So drowsy but awake, and a moderately strict bedtime schedule and bedtime routine can be very helpful for these behavioral type insomnias we see in children. Some parasomnias that you see are the ones that maturation over time will help with these kids a lot. So a lot of these go with your genetic things. So this is still in that neuro subtype that you're thinking about. So if you have same stuff like family history with migraines, this is going to be one of those same areas. If you have a parasomnia, a sleepwalking, a sleep talking, and a parent, more likely that the child is going to have this as well. So we're really looking at the types. So sleepwalking. This can actually be a big concern in kids because what are they going to do while they are walking around? So this one, are they going to go turn the stove on? Are they going to walk out the front door? Are they going to do something where their safety is at risk? This one you see with families with this positive history all the time. So sleepwalking considerations. The ones that you have to differentiate between more often are they having night terrors or sleep terrors versus nightmares. So nightmares typically are at the end of the night. So while they're in those kind of wee morning hours, sleep 4, 5, 6 a.m., last third of the night, when REM is going on, and a lot of times they can remember this. They'll tell you, I had a bad dream, this happened, I was scared, something like that, end of the night. Night terrors are when the child's mismatch, their immature neurologic system, they're supposed to get that signal that you're supposed to be paralyzed while my brain is doing all the kinds of things at night, and they're not getting that signal. So there's some immature neurologic system, and so they wake up screaming a bloody murder in the very early part of the night, so the first third part of the night, for a few minutes, and they look like they're they have a demon in them. Okay? So like glassy eyes, screaming, blood-curdling screams, and they have no idea. They do not remember the mornings at all. Their parents are completely freaked out. They're like, my child needs an exorcism. This is not good. And the kid's like, has no recollection of this. So what do you do for these? And the confusional arousals are kind of in the middle. So those ones are, don't worry about those ones as much. It's kind of literally right in the middle of that. The biggest thing to do, we'll say, are you going to do anything for nightmares? No, it's just part of sleep patterns. But for night terrors, for night terrors, what you're trying to try to do is interrupt that immature cycle. So let's say your child goes to bed at 8, and say, and we go to, you go to bed at 11, briefly wake that child up and wake them out of that sleep-wake cycle right before the parent goes to bed. Snaps them out of that immature cycle, so they're less likely to have these night terrors. So that might be, wake them up, take them to the bathroom, wake them up, give them a hug, and then right back down. So you're not trying to like get up and have a game of Monopoly, you're just trying to make sure that you're interrupting that sleep cycle. So we already talked about that. Safety precautions with sleepwalking, waking them up before you go to bed, or the parent goes to bed, and then avoiding shows or movies that are un-age appropriate. And sometimes you don't know what that is, and I'll just tell you. When I was little, for whatever reason, please tell me someone in here has seen The Sandlot. Okay, thank God. Right, the part where like they're telling ghost stories and he's like forever. I used to have nightmares about that. I'm like, it's The Sandlot, right? Like, I don't know what that says about me as a human, but like, freaks me out, right? So you sometimes won't even know what's going to freak a child out. So certainly, if you know it's not age appropriate, counsel the families. Don't set your kid up for failure. Really, there's no medications that you should be doing for night terrors or nightmares. So not something that you traditionally do. If you really think that they need something to sleep, feel like we should trazodone this kid. You should probably make sure that there's some PED Neuro. When you start thinking about circadian rhythm disorders, you start thinking this would be an older child. This would certainly be an adolescent, likely that they are done with puberty and they are in their adult physiologic state. It's more likely that you're going to see this. So again, I did put it in. Exaggerated delayed sleep is kind of that extended circadian rhythm where they do need to be up in the morning, but their body physiologically does not want to. They'll try to make up for it on the weekends. And that's where some of that cognitive emotional mismatch happens. Some of it is truly from sleep and rest and lack of. So when you're talking about what are you doing for education-wise to these families, so a lot of it is just demystifying it, right? Like you have a family that's like, I don't know why this baby won't sleep, and they're only sleeping 12 hours. Well, unfortunately, you're on this side of the bell curve. Or I don't know why this lazy teenager won't wake up at 6:30 in the morning on a Saturday. Well, so you're demystifying, you're giving a lot of education for one thing. Positive and negative reinforcement, certainly. And really, at the end of the day, it's the same as adults. So a good sleep hygiene routine. Most adults don't do that, so it's very hard to do as teenagers, something that we as adults don't mimic or don't model very well. No screens in the bedroom, cool, quiet temperatures, quiet rooms. And then I will say I do use, especially for a little bit older kids, so school age and above, short courses of melatonin to help establish a routine and then come off. Right? They're neurotypical, normal kids with normal brains. Their brain should be making melatonin on their own. But we'll use that to get them into a rhythm. And then truly, if you're using clonidine for sleep, that's probably a reason to have neurology, or at least peds on board. So, malformations of your CNS. So a couple of these that we were going to talk. So there's a few of these esoteric things. Did you guys talk about Chiari's at all in neuro? Yes? You guys were brain dead. You all had a stroke, a collective stroke in there? Okay. Yeah. Okay, that's good. For all absence seizures, collective absence seizures. So what do you treat absence seizures with? Perfect. This is great. Okay, so type 1 for Arnold Chiari, right? The way I think about this and what I tell families, your brain is just too big for your skull. You are just too smart. So the brain functionally is getting compressed at the foramen magnum. So it's pushing the cerebellar vermi are pushing on that. And you are worried from that compression of these headaches, neck pain. You can see it's severe, further neurological symptoms. The problem is you see type 1 and it's found incidentally a lot of the time, and imaging doesn't always match up. So if you get an image for something and you see a Chiari 1, you're like, do you have headaches? And you're like, nah. And you're like, okay, great. But then you have headaches and you have that. Is it really, how much do you see? So type 1 is a little bit hard to determine. Type 2 is truly an anomaly of anomalous formation of that hind brain. So you have the fourth ventricle that is elongated and can sometimes cause that inferior displacement of the vermis. So they are much more symptomatic, much more likely that a Chiari malformation type 2 is the reason for that headache rather than an incidental finding of type 1. It's just a reminder what that looks like. Normally there's lots of room for that brainstem, your cerebellar tonsils if they're trying to push through your foramen magnum. It's a type 1. If you truly have a dilated or elongated fourth ventricle there, in a type 2, that's also also the cerebellar tonsils. That's where you see the issue. So, truly an anomaly with type 2, could be incidental with type 1. A Dandy Walker malformation. I've seen this a couple of times, but I will say this one is pretty rare, things that you see. So you have complete agenesis of the cerebellar vermis. Don't even have that. That fourth ventricle is truly elongated, and your posterior fossa is enlarged. So you have kind of this collection, this triad of things that are going on. Additionally, you have hydrocephalus in the majority of cases. So you have extra pressure that's putting on the brain. And it can cause a different clinical picture. So you'll see this oftentimes present very early, where your Arnold Chiari's are sometimes presenting a little bit later. But if you have your anterior fontanelle that's open, this can the hydrocephalus can cause this rapid expansion of head size. So one of the reasons that at all the well visits, we're continually checking that head size. We need to check for things like this. This one ends up with neurosurgical. So this is the first time we've seen neurosurgery as your referral. Neurosurgery will help with that shunt if they need to. So the shunt basically just takes somewhere to offload all of the fluid and puts it down into their belly. So a ventriculoperitoneal or VP shunt is what you'll see. Same thing, you can see Guillain-Barré in children. So this is not a different entity. You probably had this, gosh, I don't even know how many courses now. Neuro and ID, all over the place. So Guillain-Barré, that demyelination that you see post-infectious is often one of the reasons. You can see it autoimmune as well. Remember, how does the paralysis go? Does it start top down or bottom up? Bottom up, so it is ascending. What organ are you worried that it is going to get to? Your diaphragm. How do you think it happens faster or slower in children? Faster. Yep. So if you start seeing ascending paralysis in a child, you need to admit that child until you know where that paralysis is going to stop. Okay? So you are worried it's going to get up into that respiratory system. Mid watch. Yep. So same stuff. IVIG. So this one is just something to think about. Another hit to Guillain-Barré, as you've already seen in the classes. We talked about you can't have honey when you were under 1, back in your block 1. Well, why again? Well, your Clostridium botulinum makes that neurotoxin, and that neurotoxin for you and I might be just fine that we can handle that, not a baby. So a baby unable to handle that, so it makes your muscles, remember which one does your muscles contract or relax in botulism? Relaxes, yep. Which one contracts? Tetanus. Yep, tetanus contracts, botulism relaxes, so you get your relaxed state and you are worried that nothing is now moving. So you will see this kid, it will have some constipation going on, potentially respiratory issues, eyelid drooping. You see this because everything is now in that relaxed state. You worry also about their gag reflex. If you don't have a gag reflex anymore, now you cannot protect your airway and you're much more likely to aspirate. This is another admission for IVIG and supportive care until the neurotoxin is cleared from your body. So this is the reason no honey, because we can control for spores and for a lot of this toxin in other places. Hard to do that when it's made in nature. So until they are 1 year old. This is probably a good place to stop. So we'll start in the muscular dystrophies on Monday. Have an excellent